sponsoring this forum to support Maryland regulated hospitals transition to ICD-10 by CMS's deadline of October 1st, 2015. During this forum, Maryland hospitals, insurance payers, and vendors will have an opportunity to converse to gain insight into the readiness, testing, best practices, and lessons learned of each other during this transition. Today, we will not define ICD-10. You can go to our website and it will have an explanation of what it is there, because I think everybody should know what it is by now. The format today is going to be very simple. First, I will start out with the hospital and payer ICD-10 surveys that the commission put out. Then the forum will be segmented into two sessions, the hospital and payer session. Each segment will have a moderator asking questions to 3 panelists. I will introduce the hospital participants, and I've asked Claudine of HSCRC to introduce the payer participants. After the payer has presented to you all, then we will have an open question and answer session for everyone. Okay? So I'm going to go this really, really fast for the survey. This is the hospital survey that we did. They just did it. And the commission put out a survey, I think it was like in March, asking the hospitals how they are faring in their transition to ICD-10. We had 30 respondents to the survey. We sent it out to all the regulated hospitals in Maryland, 5 of which were TPR hospitals, 1 was a specialty hospital, and then the other general acute hospitals gave us feedback from their survey. 90% of the organizations say they will be ready to submit ICD-10 transactions by October 1st, which is very good. 57% of the respondents completed their ICD-10 impact assessment. I asked the question in the survey, when do you expect to complete business changes, that is documentation and workflow design for the implementation? And 53% say they would expect to complete it in the 3rd quarter. And in the 2nd quarter, it was like 37%. So most of the participants say it's going to be up almost to the line of the implementation. The next question was, do you intend to conduct external testing? 53% or 16 of the hospitals said yes with sample of payers. And then only 8 and 6 said with clearinghouses and majority of payers. What is your expected date to begin external testing? A large percentage said they have already started. That's like 47%, and 10% said they have already completed it. And then another 23% said in the 3rd quarter of this year. With whom have you planned or completed your external testing? And you had multiple selections that were allowed in this category. And most of the people said they were planning to complete external testing with multiple payers, at 57%. And then the second highest was with the clearinghouses only. Oh, they can't hear me? 63 of the respondents have performed Medicare testing, which is very good. It's a very good response, because Medicare has been putting out a lot of information to ask you to test with them. And I asked, what were the top 3 obstacles that have caused delay or lack of progress in the ICD planning? This is a frequency chart. So most of them, if you just look down this chart, they're saying that competing internal priorities, ranking. So competing internal priorities, uncertainty around future delays and the implementation date, significant IT impacts, and then you have staffing, availability of test data, health plan readiness concerns, vendor readiness concerns, and budget and others. So those are the top, that's how they're ranking from highest to lowest concern. How do you plan to produce ICD-10 codes? Most of the respondents said they were going to choose ICD-10 codes directly. That's 73%, is very, very high, of course. And only like 16% said they were going to do some type of crosswalk. Have you developed a contingency plan if you're not ready? 50% said no, but it was only 15. It's almost even. 15 said no, and then 11 said yes. 11 respondents said yes. So it's almost pretty much even that some have contingency planning and some do not. Do you plan to code outpatient services using ICD-10 PCS as well as CPT Codes? Although you are not required to do so, we just asked this question to see just what are you guys up to. 63% of you said no, you will not do ICD-10 PCS codes, but I have 10 hospitals there, they're doing it. So that ends the session for the survey for the hospitals, and then next we'll present the payer survey results. 100% of the payers completed their formal impact assessment gap analysis, and over 55% of the payers completed their business process design and development. 100% of the participants will process split claims the same way as CMS's policy. Now, for the payers, there were only 7 respondents. It wasn't a lot, and I was told that the payers have been bombarded with surveys from different people that they are kind of weary of, completing surveys. So 7 was good for me, so in that sense. I asked the payers, what is your estimated date to start internal testing of full functional ICD-10 processing? And 43% they said they've already started, and 29% say they've completed it. So it's a large percentage of the 7. Do you intend to conduct internal testing, I ask? 71% said yes with a sample of providers, and 29% only with clearinghouses. Sorry. What is your estimated date to begin external testing? 14% say they've completed it. 43% say they have started it. So they've already begun their external testing. Do you plan to perform external testing with Maryland institutions? I had to ask that question. And multiple selections were allowed. 43 said yes with hospitals. 29% said with other providers. 43% said with clearinghouses. Only 14% said no. And then this other right here, they just commented on why they selected yes or no. Those are just their comments in that section. What are the top 3 obstacles that have caused delay or lack of progress in their planning and implementation of ICD-10? So the payers said they're really concerned about you hospitals, 100%. Secondly, they say they are concerned about potential delays of implementation date from the CMS. And then the other category just explained why again. And another is like 43% say they were concerned about the vendor readiness. I asked, what is your primary strategy for processing claims? They say they would use, well, 57% say they would use direct ICD-10 processing. Some of them would use crosswalking, and pretty much, crosswalking from ICD-10 like 14%, and then they would use a dual process of crosswalking and direct processing of 28%. It's only like 2 hospitals and 1 hospital, so it's a small group, but these percentages make like it's bigger, but not too much bigger. 57% of the respondents developed a contingency plan if they're not ready by October 1st. So, and only a few said they just didn't know. And that's it for the slideshow. So now we will go to the hospital session, where we have a moderator and 3 panelists for the hospital section. And I would like to introduce the panelists and the moderator for the session. I'm going to take this up. I would like to introduce the moderator first. His name is Stanley. Can you raise your hand? Natchinson. He is the principal of Natchinson Advisors, a health IT consulting firm dedicated to finding innovative uses for healthcare information technology and encouraging its adoption. The firm serves a number of clients, including the Cooperative Exchange, EHNAC, Instimed, ICD, Logic, and the American Osteopathic Association. Stanley is focusing on assisting healthcare providers, vendors, and plans with their ICD-10 and other regulatory implementations, and providing advice on HIT industry status and trends. Stanley is the author of an authoritative paper on the cost of ICD-10 for physician practices, and is coaching work groups for both HIMSS and READY. Stanley served for over 30 years in the U.S. Department of Health and Human Services in a variety of statistical management and health technology positions. His last 10 years prior to his 2007 retirement were spent in developing HIPAA policies, regulations, and implementation planning and monitoring, beginning CMS's work on personal health records and serving as the CMS liaison with several industry organizations, including READY and HITSP. He brings a wealth of experience and information regarding the use of standards and technology in the healthcare industry. Thank you, Stanley. We have 3 hospital panelists. We have Robin, raise your hand, Emmerich. She's the Director of HIM and Privacy Officer of Union Hospital of Cecil County. Next, we have Heather Hill, and she's the Director of Revenue Integrity of CDMC. And lastly, we have Jody Reedy. She's the ICD-10 Project Manager and Partner with I3 Healthcare Consulting, LLC. Thank you all for participating in this forum. Would you like to answer the question?
Sure. And just a brief comment on the survey results. Many organizations have done surveys both on a local and national level. The results in Maryland pretty much reflect what's going on in the rest of the country, with a majority of health plans and providers doing a pretty good job of making sure they meet the October 1st implementation date, but there's still a significant percentage, and I think you saw some of these, that thought they could wait until July, August, and September of this year to do some testing, or not be finished with their business processes until July, August, and September. So I think we still have an issue with about 20 to 25% of, not necessarily institutions, but particularly physician practices, that may not be as far as advanced as we'd like to see in the industry. So we're keeping our fingers crossed that October 1st will be relatively smooth. And again, just as another comment, there's several bills that you all might have seen introduced in Congress to delay or fiddle around with the October 1st date. Neither of those bills has much of a chance of being enacted. They were introduced by congresspersons who, although they were both medical professionals, one's a doctor, the other's a nurse, but none of these folks have any influence in the particular committees that have jurisdiction under these bills, and all of the committee chairpersons have indicated their support for October 1st date. So no one should be thinking that there is a good possibility of any further delay. I think that's very important to understand, so we really do need to move ahead. And speaking of moving ahead, I will go ahead and ask the questions and give our panelists an opportunity to talk about where their institutions are in the whole ICD-10 transition process and how quickly they're moving towards October 1st. So the first question is, where do you guys stand at the moment regarding ICD-10 implementation? How close are you to completing, and how comfortable do you feel about October 1st?
Okay. At Union, we have been dual coding since spring of 2013. Our coders are trained, ready to go. We are utilizing our coding team, our CDI team, to work with our providers regarding documentation. We use the Meditech system, and we have added qualifiers to our system that are actually assisting the physicians to provide the greater specificity within the documentation. We've done department by department training, registration, case management, quality, risk. So I think we're ready to go.
That's terrific. And I think this indicates very much the impact throughout the hospital of ICD-10. It's not just a CDI issue.
Correct.
It affects almost everyone, or virtually everyone in the hospital. Heather, how are things at GBMC?
I think things at GBMC are going well. We have a massive plan in process because it's not just the hospital, it's also our ACO, our physician practices that we own, and Gilchrist Hospice Care. And so that's all under my umbrella of making sure that everybody is ready for ICD-10. We too have training in force now, I guess. We have a couple of different vendors that we're using. We're focusing on physician documentation as one part of it. We have just started our dual coding within the last 6 weeks, so we're working with that. We have implemented Optum CAC product. It's been a little bit of a struggle, but we have that in place now on both the outpatient and inpatient side. So that's one of the reasons we've been a little bit slow in doing our dual coding. We have a very comprehensive and integrated plan for monitoring on the business side. I think a lot of people forget that it's not just documentation and coding. That's a big part of it, obviously, to get our bills out the door, but with our testing with our payers, we're working on that very extensively. But from the business side of it, making sure that reports that are being sent out are moved into the I-10 world. If you have reports that are set by diagnosis codes, you need to make sure that the new settings on those reports will be able to either take an ICD-10 code or find an ICD-10 code. So your data reporting warehouse and other areas such as that. Trending, how are we going to trend from 2014 and 15 ahead? So if we want to look back and say how many of this procedure have we done for business development purposes, you need to be able to figure out what did it look like back in the I-9 world and transfer it into the I-10 world without losing any of that data integrity. So that's a big piece of what we're working on now, all of the systems. We are, unfortunately, ICD-10 is running along side by side with our conversion to Epic. We just started that process. So we are a Meditech hospital, and we are in a freeze within Meditech. So sometimes it's a little problematic if we find things that we think need to be improved upon now in the Meditech world. There's an entire process we have to go through to convince the powers that be that, yes, you need to shift some resources over back to the old legacy system of Meditech to make these things happen, because as I keep trying to remind people, ICD-10 is coming first. We have to do that first. We're not slated to go live with Epic until October 1st of 2016. So God help me if Congress decides to enact something and move it a year out. You all heard that here first. I'm not going to do that headache as well. So I think we are on we're on a good road. We have a heat map that we use and meet with our executive sponsor on a monthly basis, and we're starting to transition some roles at GBMC as well. And so with that, we're going to shift into a little bit more quickly, but most of what we have on there is in green or yellow. We have a few reds, but I think we're well on our way.
And I think we'll talk about a couple of those reds later, but Heather makes an excellent point in that October 1st is not an end date. One of the fears that folks have is that on October 1st, there's going to be this big celebration by all these steering committees and vendors and such. That they're going to, have a big party and then say, all right, now let's get back to doing what we used to do. You will not be doing what you used to do. You will be living in an ICD-10 world for the foreseeable future. So there's a lot of impacts, again, making sure that all the stuff we're preparing for actually happens, and all of the end things, the reports and such, are correct.
And billing and mitigation strategies for when your denials go through the roof and you can't get your bills to drop because something hit an edit somewhere that you weren't expecting, and what do you do when patients show up in your outpatient areas and they have a referral and it still has an ICD-9 code on it because it's from a physician practice that may not be up, they're not ready for ICD-10, or they're still struggling as well. You know, how much risk are we willing to take? That's a big conversation we're having now. How far are we willing to go before we start telling patients you're going to need to go back to your physician's office and get the right information? Because that, of course, has a huge public face impact and public image impact.
Absolutely. And I think that the plans will help us kind of work through some of these prior authorization and other transition issues that we're going to be dealing with. But that's the second half of the program. Jody, University of Maryland.
We have a little bit of all of that going on at University with all of the different hospitals that are part of the health system. Some of them are on Meditech, some are on Epic, some are on STAR still, and 3 of them go live on Epic 37 days after we go live on ICD-10. So trying to make sure that you have that maintained focus on what you need right now and what we need to get through that transition is a little bit of a struggle, although the team is working pretty well together to do that. But most of our efforts in the last year leading up to now have been really focused on, as Robin indicated, focused on working with the CDI teams, making sure all of our queries and all of our technology that they use, the documentation requirements, all of the physicians have been trained group by group. So you start with the cardiologists and you move through the specialties to make sure that they understand what the differences are in the documentation that will be required to code on ICD-10. So the heavy lifting on the inpatient side has been our primary focus over the last, I'd say, 6 or 7 months, which I felt, or at least we all collectively felt, that's where our biggest risk resided. Our systems, for the most part, are really helping us on the outpatient side in terms of being able to be upgraded and identifying in those clinical pathways where we need to capture additional documentation to support I-10 coding. We did not install a CAC, computer-assisted coding, anywhere, but I'm terribly curious about the results, and I'm looking for Heather to give us some kind of report at some point in the future how that went and how it's supporting you through I-10 to see if that's a direction maybe we should start looking to go. But so systems are in remediation. We've had a couple of snafus on for a couple of our systems, but they're all working well. We're all dual coding. We're close to dual coding everywhere. All of our coders are trained. Our infrastructure is in place. We have the plan for the training. All of those things are moving quickly. I would say at this point, the general feeling is that no one is panicking yet. I anticipate we will start to get that panicky feeling in August. That's when I expect senior leadership to really spin around and look at us instead of the Epic team and go, are we going to be ready? Can we drop bills? How delayed will my cash be? And what do you expect to see from a denial perspective coming back from the payers? And are the payers ready? And did we test? Did we test, and can you look me in the eye and say that you did everything you absolutely should have before we get to 10-1 to be able to flip the switch? So, and in some cases, I think our team through Nick Kelly and that whole group of everybody in UMMS that's been working diligently to do as much testing as we possibly can has been going very well. We haven't seen any huge glitches anywhere. However, we've been jerry-rigging some of those processes to be able to get some of our claims to go through. So I'm waiting a bit to see if we can get a little closer to a live environment for testing some of that. But so far, I think we've got our arms around all of the major complexities and the things that we needed to have our arms around for university. But we'll have a better sense probably in August as we get a little closer to see just how prepared everyone feels to be able to really flip it.
Great. Thank you very much. Some key points have been some tests, both internal and external. Everybody is still sort of waiting to see what happens when you move into production. Hopefully the testing has mirrored some of what's actually going to happen, but that's really a key point. One of the things that we found, at least nationwide, is that people are beginning to learn a lot from dual coding and even some of their internal testing, as well as some external testing. So from from the hospital standpoint, looking at some of the dual coding that you've done and comparing the 9 coding and potential DRGs to the 10 coding and DRGs, what have you found in some of your dual coding? Do you see specific shifts, very few shifts, or a lot of shifts, and why?
I think that we definitely saw some shifts.
Can you pick up the mic? They're having trouble hearing us on the other line, and there's approximately like 78 people on the webinar.
Well, just the question that we're moving to now, and you can let us know if this is better, is the hospitals that have done a lot of internal testing, especially, and external testing around the dual coding. What are the lessons that you've learned in terms of the potential for both DRG and outpatient shifts and changes in coding patterns?
Okay, we definitely have seen a shift with the moving to ICD-10. We have had great success with CMS through Relay Health. We've tested twice with them. We have also tested with Premier for our quality data, and that has gone exceptionally well for us. We worried in the beginning with the coders, making sure that they truly were ready for ICD-10. It's not just about the changing of a code book. It's about making sure that they completely understand the anatomy, the physiology, the pharmacology, each and every piece of the puzzle, because without that background, it's going to be very difficult in 10 for them to move forward effectively. As we look at the data, we're seeing a lot more specificity within our physicians' documentation, just because we have moved to the dual coding process.
And you said you've seen a couple of shifts. Have you been able to pinpoint either the causes or at least the DRGs that you've seen shifts in?
Not so much the DRG, but the cause definitely was the documentation, or the lack thereof, the documentation.
Great. Thank you. Heather, so what have you seen in both your internal and external testing?
Well, on the internal side, just when it comes to doing the dual coding, as I said, we are very early in on it, so we really don't have a lot of results yet, and we haven't looked at DRGs or DRG shifts or anything yet. That's actually on our work plan to start within the next couple of weeks to see how we want to tackle that and what it's going to look like for us. Externally, we did the pipeline test. We are also a Relay Health customer, so we're dependent on them. Obviously, because we use a clearinghouse, we cannot test directly. So those tests went just fine, just like they did for everybody else who was a Relay Health customer. So we are working on testing, and I think a lot of other people are. We are a Kaiser hospital, so we will be testing with Kaiser. I think we did some early on, tried to do some early on, and it was right before the delay was announced last year, so it kind of got tabled for a while, but that's actively being worked on through all of our entities, through the hospital, the physician groups, and Gilchrist. So we're working on that. And then the Care First pipelines just opened up last week. I know there were meetings, and probably many of you were a part of that as well, to start getting that set up. So that's what we're seeing now. We're hopeful. As Jody mentioned, we have in our testing so far had to jerry-rig a couple of things because the systems are not all up and running and talking to one another. So we're putting some things in the test system, and we're quote unquote fixing them to get them to leap into the next system and push them through. And we are hopeful. We're getting some updates from Meditech that just came in. They're being tested internally, and I think our goal is to have them done and finish being tested this week or Monday, and then we'll be able to move those things forward, and then we're hoping that the pipelines will open up a little bit more widely.
And just another learning example, we've finally begun to realize in this ICD-10 transition how much we all interact in the healthcare industry, that that hospitals can't possibly accomplish this all by themselves, that they need the cooperation of their vendors, and the vendors should have been ready early enough for the hospitals to go ahead and do the implementation. And in terms of dealing with health plans, again, the health plans have to be ready with their test environments and with their policies so that the hospitals can understand what they need to do even before they start testing. So there's a lot of interactions that are being discovered here, and hopefully we'll learn some lessons for future transitions. Jody?
Similar to Heather, we are new in a lot of our dual coding that we can capture and track and report on. So historically, we were doing some dual coding, but our systems weren't ready yet to hold that code long enough for us to be able to do a bunch of reporting on that. We're moving into that now and have aggressive plans to be able to do a lot of that reporting and digging in and understanding what those shifts might be. So a similar place to where Heather and GBMC reside. As for external testing, we'll test with anybody who wants to test with us. For whatever reason, it's not an attractive test partner. We just don't get selected. So luckily we were in with the Care First testing that's coming up, which is fabulous, one of our primary payers here. So we are looking forward to that and getting some of the good results out of that. We test everywhere we can. We're testing through Relay, who's also our vendor as well, and those have been very successful so far. It's complicated since we're on so many different systems and so many different locations across the health system. It gets more complicated. God bless Nick for coordinating all of that. But so far so good, and we're looking forward to the results coming out of Care First.
Great. Again, from testing, at least on a national basis, we're beginning to see some results both from hospitals and from health plans. Interestingly enough, on the DRG shifts and even on the outpatient shifts, the general feeling is that those will be minimal, assuming that both the documentation and the coding is correct from the provider. Many of the DRG shifts that are coming out of testing, when investigated by both the health plan and the provider, found that either the ICD-10 code was incorrect or the original ICD-9 code compared to originally submitted was incorrect. So we're going to see a number of items changing simply because of the fact that we're doing better documentation and hopefully more accurate coding. There were a couple of small areas that were pointed out that on the OBGYN side, again for inpatients, there were some shifts in DRGs, and also, this is an interesting one, for psychoses in some of the mental health areas, there have been some shifts in the DRG. So those are some interesting things. But the key here, again, and I'm glad that the Maryland Hospital Association and HSCRC is doing this, is to share some of these results so we learn from each other. We don't have to duplicate every test for ourselves. So I really appreciate the panelists sharing this. So let's move on a little bit to, I think, some of the key obstacles that you might have faced and how perhaps you overcame them or you're still dealing with them. What are the 2 or 3 things that really got in your way in moving forward on ICD-10 implementation?
I think one of the problems that we encountered was when we began to look at sending out bills. So we turned on the dual coding process, and all of a sudden, I-10 codes were going out instead of the I-9 codes going out. We fixed that very quickly. But, that basically was the only problem that we have really encountered, because we have the new Meditech system. And, we worked very carefully as we implemented this process to make sure that we would really mitigate any issues that we were having. But that's been truly the only glitch that we have. One of a system issue, we did have a problem with our endo product. We still have that problem. We have not been able to get
I'm sorry, what is an endo product?
Endoscopy,
Got it.
or endoscopy software,
okay.
And we are trying to work through that process to get that piece fixed. It's a patch, but it's been a long process getting that fixed.
Great. Again, it's amazing how many places within a hospital ICD-10 touches.
Absolutely.
I'd be
be interested in finding out what your endoscopy product is, just because. At GBMC, where to begin? Our biggest headache is Epic. Hello, all of you Epic users out there. No, we have a lot. We're having a lot of turnover at the executive level in our hospital right now. So keeping people engaged at the higher levels has. I don't think it's been a struggle. We keep working despite it, and keep getting things done. I would say, personally, one of the biggest hurdles that I know of that we've had is in our MIS department in general. We're a community hospital. We have found that we have a bajillion other systems across the hospital system that departments have. Like endoscopy has their own, and Oncolog in the cancer center, and I don't even know, the radiation oncology uses their own system, radiology uses their system, and then if it's advanced radiology, it's something completely different. And cataloging them, and then finding out who is the owner, and people not wanting to take responsibility for ownership of a system. So we can't even find out if that system is upgraded, if it is ready for ICD-10, not even to talk about testing, because then you have to get the business owner in that department to spearhead that, because we just don't have the knowledge base. We don't use the system on a regular basis. So that has been a struggle, and alongside of that is run our reporting. We, as you all probably do, run a million reports, it seems, and trying to go through those reports that are currently ICD-9 code based for however you want to define that. There's something about an ICD-9 code that drives that report, shows up on that report, dances around the border of that report, whatever it is. So finding all of those and then letting the owners of them know, finding out, do you even still use this report? That's one of those things, because we don't have the bandwidth to fix every single report if there are 1,500 of them, if we find out that only 250 are actually used. So that's also been a struggle of finding out who owns reports and what they're really doing with them, and things like that. So I would say from my perspective, those have been the two biggest hurdles. And then the last hurdle is just is resources, internal resources. And because of all the competing priorities, I'm probably one of those people that put that as one of our head things. I don't remember. But obviously there are so many other things that are going on. We struggled very much over the last year because of meaningful use and Meditech deploying resources toward meaningful use rather than ICD-10, so we were delayed in getting certain things upgraded in the Meditech system and trying to play catch up with that. So that's been a little bit of a challenge, and like Jody was just saying, the next 4 months, I think that's going to tell the tale. And for me personally, I know I was introduced as Director of Revenue Integrity, but I was just promoted to the Chief Compliance Officer for GBMC Health System. So I didn't.
Congratulations.
Thank you. I did not lose I didn't lose any of the other responsibilities, though. I still have everything I had before, plus I get a whole lot of new stuff. And so my calendar is quickly filling up with all of these Chief Compliance Officer sorts of things when it was already stacked with ICD-10 sorts of things and CDI, because I'm director of the CDI program as well. So it's very, it's starting to get to that boiling point. So I think the challenges, we've come up against challenges, we've gotten through them, and I think it's just, I don't want to say it's not picking at, it's just reinforcing with your the powers that be above you, and then all of your teams that you have to work with, that you just have to remind them that you're still there, and we're still working on this, and we're not done yet, and we're, however many, I think it's probably now 120 some days out, so on and so forth. So that's kind of what we've been seeing at GBMC.
So it sounds like you're doing everything at GBMC. Pretty much. Thank you for that. Thanks for being here. I'm sorry, Jody, some of your key obstacles and challenges.
I'm going to frame it in sort of a historical obstacles and then the ones I expect to come up against in the next several months. And historically, it's been really the tentative nature of the go-live date. has just killed us over and over and over again. Every time we get momentum in this project and everyone starts to pay attention, we get somebody introducing another bill to delay it, and that sends shock waves rippling across the entire organization. I immediately get 30 emails from different people with the same links to the same article saying, is it true? Are we going to delay? Do we get to back off now and stop doing this work? Because we'd really like to just focus on Epic, if you don't mind. So that piece, and still today on May 28th, when we go live on October 1st, is still a going concern. And it's still out there, and it's still lingering, and there's still people out there introducing chaos into that, and every time that happens, it causes just agony. So that piece, and maintaining focus, and one of the things we had to do was rebrand a bit and go back and say, okay, for the CDI piece of this, we're going to call it clinical documentation improvement, and we're going to do this work regardless of whether we go live on ICD-10 or not. So we had to rebrand a bit and refocus and say, this is going to happen. I don't care what you say with ICD-10. I don't care if we go live in 2020. We're still going to do this work, and it will not stop. And I need executive support to make that happen, which they did, which was fabulous. But that shift, as the CDI team itself, the approach that we asked them to take was a bit of a challenge historically too, because it was different than what they had been doing previously. And of course, unions change and everybody likes to push back. But we asked them to actively engage with physicians in the education of our docs on what the documentation requirements are. The physicians don't want to go sit in a classroom, and they don't want to sit and have someone preach at them. They want to use existing infrastructure to be able to get the education they need to understand the documentation differences. So they want to use their CDI folks, and they want to use the querying process that they already have, and they want to have feedback that is relevant and timely to them and specific to their charts and all of those things. And the only way to do that is to use those CDI folks to do it. Well, the CDI folks, historically, in some of our hospitals, that's not 100% the role they played. They were primarily querying people. They would go into their systems and query, but they wouldn't spend a whole lot of time talking to the doctors, and we're asking that to change pretty fundamentally. You have to get out there and talk to them and say, here's what we're seeing. If you do this, you can cut down your querying volume by X percentage. So we're migrating to that kind of a model, and there's a little bit of pain involved with that. So historically, those are some of the things that we would see. Going forward, the things that are starting to keep me up at night are maintaining that dual coding pace. So once they start dual coding, you don't want them to stop. They need to do that from now until forever, and it's different. Again, it's a change, but getting them to understand, no, you can't just do 9 anymore. You have to do both. You have to be able to be conversant in this. You need to be experienced in it by the time we go live on I-10 on 10.1, and you can't stop. Same with the CDI people. You can't stop querying these doctors. By the time we get to 10.1, we want that to be a part of their everyday language so that 10.1 is a non-event. That's the goal. 10.1 means nothing to our inpatient side of the house because we're already doing it everywhere, and we're already querying everything, and we've trained everybody, and it's not an event. It's just another day for them in the new world. So maintaining that dual coding pace, maintaining that focus, and then really the next challenge is making sure that everybody who needs to be part of a rapid response team on and through 10.1 and probably for the next couple of months beyond, and then some to some degree, get that team focused, understanding what their role will be, what data they're going to have to look at, and understand where they need to start focusing immediately to solve problems if we do have denial rates that go crazy, or we're not able to get bills out for whatever reason, or we have a system glitch that we weren't prepared for. Whatever that response that we need is, we can immediately zero in on it and fix it so we can limit the amount of time we have the financial pain.
Thanks, Jody, and you've actually anticipated so the final question I want to give the audience and also the folks on the phone a few minutes to ask questions. So we've got roughly 4 months left, and probably really less than that because you don't want to be sort of working up until the last minute. So in these last couple of months, what are the key items that you're going to be focusing on?
Okay, we're going to be focusing at Union on our query forms, making sure that we are ready to go with that process, but we're also, just like Heather and I believe Jody also spoke about, is working with our providers in the community to make sure that when they're submitting those documents for outpatient testing, that they are giving us the appropriate, either the verbiage or the code, to be able to code those records appropriately. That is our major focus as we're coming to the end.
Thank you. Heather?
At GBMC, I will second, as Robin just said, we're doing the same thing we are right now, also doing with reviewing all of the queries, changing our query formats if need be, preparing to build new ones based off of what we're finding in our dual coding. Physician education is at the top of our list. I spent pretty much all day yesterday in sessions with individual physicians, talking to them about their documentation and how they can improve it. We have many sessions set up moving through the summer and into the fall. We did many last fall as well, and so we're continuing that. Our community physicians, of course, are a big piece. We're helping them where we can, and we are letting them know what our expectations are through a series of communications, again, to make sure that they understand the need for ICD-10 codes, or at the very least verbiage. We have a mitigation strategy for our frontline with our patient access reps and those people in the labs, in the pathology areas that are receiving specimens. They're getting paper forms on specimens. They don't even see a patient. And it might be, you know, they get something at 9 o'clock at night by the time it gets dropped off, and what do they do with that? So those strategies are definitely being worked out. So I think through the summer, those are the main sorts of things that we're focusing on. And then, of course, testing, and getting the systems moving in the right direction.
Yeah, I will reiterate points made by Robin and Heather for the readiness of your community docs, and are they ready to give you an I-10 code on any of their referrals or their scripts that they're sending over with their patients? And if not, will they be? Are their systems ready? Are their people trained? Are their office staff or their coders trained on ICD-10? And if you're reliant on your community docs for that, what's your sense of that? So we have some hospitals that are very heavily reliant on that, and university and some of the central region hospitals that are supported by the FPI organization, and they will be ready as well. So we've got the focus on those community hospitals, very focused on that community physician space, and reaching out to them to understand what their readiness will be. We're also, as Heather mentioned, focused on the service access areas and creating what I'm going to call a guiding template, if you will, for every different type of patient that comes into your hospital, how they come in, how does the script come in, do they come in with something in their hand, does it come across electronically, does it have an I-10 code on it? If it doesn't, what do you do about it? Do you need to give them some sort of lookup capability for the service access people? Do your systems require a code to give a date and time or a schedule for those patients who are calling in? Will every payer require a code to be able to get an authorization number for those services that require an auth? How will you get it if you don't have it? Do you delay the service if you don't have it? You call back the physician office to get it. Is the physician office prepared for the kind of volume of calls that they might get on or about 10/1 or the couple of weeks prior? The kind of volume that they might get for calls. Have you talked to them about it through your highest recruiting doctors? Those kinds of things we want to be prepared for and understand what will happen, and is there a different way we need to communicate with our provider community during that transition. So, and then the encounter forms, and if anyone's still using paper-based encounter forms, and do those have codes on them, and are we checkboxing them, and are those ready, and all of those kinds of things are really where we're trying to get down into the minutiae of the detail and be prepared.
Okay, we're going to take this to 10 o'clock, and then after the payer panel, you'll have an opportunity to ask everyone questions. So I get a chance to ask one or two more questions. So what, given the fact that with the benefit of hindsight now, and perhaps to provide some lessons for folks that are not as far along as you are, what kinds of things might you have done differently if you had to do it all over again, or if you were not as far along as you are today?
Well, I think that
at least things under your control. I know you'd like to say to Congress, please don't mess with this, but
I'm very good friends with the lawmakers. From a organizational perspective, we probably wouldn't have done anything different. We prepared for this for such a long time, as some places stopped when the delay was put into play, and they thought, okay, we'll get to that later. We chose not to do that, and we kept on going, and and everybody was engaged, the whole multidisciplinary team. So at this point, I would say I wouldn't have done anything different if I had to go back and do it again.
Great, but the fact that you actually had more time probably was to your benefit then, that you took advantage of the extra time rather than pushing things off.
Push it aside. Absolutely.
Well, in hindsight, I may have respectfully declined the great opportunity to lead the ICD. The mantle on which...
No, I meant what should GDMC do?
Okay, that's not what
I'm sorry, I wasn't clear on my question.
Oh. Sorry about that. I'm with you. I'm with you, Stan. I got you. I think that I would have been, definitely would have been more forceful in getting the... forcing, I don't know if you can say that, but the buy-in, trying to, not force, obviously, to persuade people. I would have spent more time trying to persuade people that this is, it's important, and we need your help, and not taking on as much myself personally as I ended up taking on. I mean, I did actually fall into the role. I was not originally this person. When the delay came back in 2012, when that delay came, the person who was the project manager was moved to another role. I was just a SME, a subject matter expert there to guide and assist and give some resource information to. And when she stepped aside, apparently I was looking the other way, and I was the only one left in the front of the line. So it came to me. But trying to get those relationships internally and getting more buy-in on a more regular basis, because it's been very sporadic. It's been, okay, we have to do this now, and then we'll meet again in 3 weeks. And in 3 weeks, it's like, oh, we were supposed to do that, weren't we? Okay, well, I'm going to do it now. And I'm guilty of that as well because of other competing priorities. So I think trying to build an internal team that was a little stronger and a little bit more cohesive probably would be something that I would recommend. If you don't have one now and you're still working, please do that. Try to pull your your soldiers together and get your army together. And Jody mentioned about the delays. That has been a killer. And it does get frustrating, and it does get a little bit disheartening when you walk down the hall and you have a senior C-level person say, hey, what about that ICD-10? You really think it's going to happen? I don't need those people up at that level spouting that. I need, and so I've had some of those crucial conversations trying to explain to them, yes, it really is going to happen, and we really do need to do this, so I really would appreciate your support in public as well as privately, because, again, it can get a little disheartening when everybody thinks it's a big joke.
Yeah, I'll just say that I love to remind people that the regulation requiring ICD-10 was actually published by the federal government in January of 2009. So we've been doing this for 6.5 years, and frankly, of the 6.5 years that we've been giving, my guess is most institutions and others have spent about 1.5 years worth of work during that 6-year period of time. And what people are finding is that the amount of work and the resources were way more than they initially expected. And I think that's part of the reason we're in the position we're in. Jody?
What would I do differently? I think we are doing differently. So similar to Robin, we've managed to take advantage of the delay that we were given and listen a little more closely to some of our physician stakeholders in our community out there to say they weren't pleased with our original approach. It had great intention and great people supporting it, but they just didn't like it. So even the best intentions, we had to adjust that completely to be able to match what they really felt like they needed for us to get through this transition. So I think some of the changes that we made last spring with the delay that we received, I think those are if we were going to make a change, that's when we should have done it, and we did. What I would have preferred, we stopped a lot of our IT activity at that time, and I wish we hadn't, because we were a little bit of behind in some cases, not all, but in a couple of cases where I would have liked to have been a little further ahead. So I wish we hadn't had to do that, but we had other hospitals going live on Epic and competing resources, and they don't know if you're going to go live or not, and this could get delayed again. And so all of that can kind of conspire against us a bit over last summer that probably delayed a couple of things that I would wish were a little further along. But for the most part, we adjusted where I felt like we should have on the really critically important things, and that was really well received. So.
Excellent. I think we're going to wrap this up and give the plans an opportunity to answer some of these same questions. We're certainly fortunate here in Maryland to have 3 hospitals that have taken ICD-10 seriously and done a tremendous amount of work in moving towards that October 1st, now 2015 date. So I want to thank all 3 of you on the panel for your work here.
Okay, good morning. My name is Claudine Williams. I am the Associate Director of Data Management and Policy at the HSCRC, and I'm here to introduce Charlotte Kohler, who is the President of Kohler Healthcare Consulting with over 30 years of healthcare experience, starting with nursing on the clinical side to CFO and compliance officer. Ms. Kohler has experience with coding surveys, coding of outpatient services, charge and coding capture improvement, and hospital charge master improvements for both Maryland and non-Maryland hospitals. She provides ICD-10 education to physicians and coders. She reviews current charging and coding methodology, both CPT and ICD-9-CM, to ascertain potential audit liability to improve income potential. In addition, she's developed many courses in educational materials relating to these topics. Charlotte is contacted frequently to help providers work through difficult coding and compliance issues. So we're very thankful to have her leading, being moderator for this panel. And our payer panelists who are gracious enough to join us. We have Doria McKenzie. She's the Program Director, Organizational Change Management, Corporate Systems and Enterprise Programs, Technical and Operational Support at Care First. Like the title of the thing is longer than her name. Right. Welcome. We also have Catherine Gard, who's the ICD-10 Program Manager at AmeriGroup. Welcome. And Stacy Watson, Senior Director, Head of Aetna's ICD-10 PMO at Aetna. Thank you very much for joining us.
Well, good morning, and thank you for coming today. Certainly, as we've talked to the hospitals, we'd like to have each of you give us sort of a discussion, a thought process, a status report as such on where you stand on ICD-10 and some of your travels to get there. So you want to start out?
Sure. For those on the phone, this is Stacy Watson with Aetna. You know, I think from an ICD-10 readiness perspective, much like some of our provider or health system partners here, that, you know, I think we stayed the course. So as the delays would come and senior leadership would say, great, we can take all that really great resource and use it somewhere else, we would sort of say, yes, but just think of the testing we could do, or think of. So I think on the whole, from a readiness perspective, you know, Aetna feels ready for 10-1. We've done significant internal testing. We've conducted external testing with several large health systems. All of that has proven to us anyway that we're ready. We can talk later about some of the things we've found in some of those tests, but on the whole, I believe, you know, we are ready. But, you know, from an obstacle perspective, I don't think any of us can overstate the delays, not just from a disruption of the calendar or your plan, but it's just the emotional and sort of strategic disruption that creates, and trying to get people to stay focused and stay the course when the mixed messages are great. And we've actually had opportunity to talk to CMS, you know, sort of individually in the last month or so, and, you know, express that to them. I'm sure we are not the first or the only institutions or people to say that, and have gotten, I think, a high level of confidence back that, you know, the focus is to maintain the 10-1 date. So fingers crossed, there we go. But I think we're ready.
Oh, that's good. Doria, would you like to give some idea on Care First?
Sure. So I'm Doria McKenzie from Care First with a very long title. And actually, I think that was taken from my signature. So I'm actually just the program director on the ICD program with Care First. So my focus and why I think my director asked me to come here today is I'm focused on organizational readiness and third-party readiness. So it's kind of a unique position to have on the ICD-10 program, but I would say Care First is ready, has been ready. We never say we stopped, we say we ramped down. But we are definitely back in full mode. We've tested all of our internal systems. We're ramping up for end-to-end testing with providers starting on June 8th. And so everything that we've seen so far is going extremely well. And the way that we sort of define success, we define it, we've been working with the provider relations group to help providers kind of define success for themselves, and then what success means to us internally at Care First. And so far, you know, I think we're moving along. All the signs are sort of pointing to, just like Etna mentioned, we're on target.
That's
so
good. That's good.
Going well.
Kathy, can you take the mic there and give us some insight from AmeriGroup?
Hi, thank you. Yes. From an AmeriGroup standpoint, as with my peers here, we're ready. We've been ready. We've done extensive internal testing, and we're doing extensive external testing as well, testing with some of the providers up here on the panel with us today. I'd say from that standpoint, we see the things processing. They're processing well, not finding a lot of surprises. I really echo what some of the hospital partners said up here today as far as, you know, things matching, the shifts not being as significant. That's a good sign. It's a good sign for all of us that things are working that way. Overall, I think is we're ready now in the sense that we're going to begin accepting authorizations for services, dates of services of 10-1 and forward, or dates of discharge 10-1 and forward, beginning next week, beginning on June 1st. And so for us, the ready and the go lives are actually starting now. And we're going to continue in those testing processes. And as we said, we'll talk a little bit more about that as this goes on. But I think it's really kind of an awareness needs to be out there that it isn't just October 1st, it's also now for many of us and for many of our processes, because as we start to move in the coming months, we're going to start having authorizations come in for dates of service and date of discharge of 10-1 and forward. And so that means we're going to kick into gear, all of us, even before 10-1.
Kathy, can you continue on, because you brought up a topic with regard to the authorizations, which I think is top of mind for a lot of the hospital as well as the physician groups. And so when we talk about being ready now, when someone calls in to get an authorization, and let's say that date of service is 10-2, but all they have is an ICD-9 code, what happens then?
That's the right question, and it's the tough answer. And the tough answer is, luckily, you've got a little bit of time. You got to go back and you got to get that 10 code. It's just got to be that way. If the authorization, and I'm going to kind of break it down just a little bit.
That would be good.
If the authorization exists today and it spans, at least for our organization, we've done extensive testing and checking, and you're not going to have to go back and change existing authorizations. Our claims matching will try to match against the diagnosis code, but that isn't the only match. And so it'll drop to other matches to make that auth and that claim match successful. So that's wonderful news for us and the effort that we'd have to put forward, but it's also wonderful news for you guys and the efforts that you might have to put forward. The key, though, is auth intake for dates of service and date of discharge 10-1 and forward. They really will start to have to come in beginning now, really beginning June 1st, but that's effectively now. They will have to start to come in with those 10 codes, and we're going to request that if they don't have the 10 codes, that you go back and you try again and then come back with the 10 code. The one thing that we can't do, really, is two things that we can't do, and it's probably the same for my peers here. We can't create the codes for you, right? That would be basically against the law. It's against the right processes. And so we've got to have you give us the code that matches your evidence, your medical record, that sort of a thing. And so we didn't choose a crosswalk type of a solution. It's really not, the best solution, is for all the reasons that we already know. And so we've got to depend on each other, and then that we've got to require the right code.
That's very helpful. I think that a lot of people here, as well as on the phone, were interested in that very particular question and answer. Along with that, I think that that's going to help us move forward on I-10 to get to the right answer, and it's going to put a burden, not an undue burden, but it's going to push the hospitals to have to be able to get that information, and the physicians, which I think from the hospital side, I mean, and I will tell from a personal side, I think the physicians aren't ready yet. Especially those that aren't part of a hospital system. They are just not ready. So this is going to be quite an interesting time. Before we go to Daria, how about have you sent out notifications to providers and suppliers with regard to this June 1 date?
Some of that's coming out now. We've had some notices on our website for some time now. We've had notices in newsletters and other informational things that have gone out, and we're preparing a blast fax that will go out as well. So we've been sort of having the message out for a while that it is June 1st to start, it is June 1st coming, and we're intensifying that messaging as we're getting closer to the time.
And thank you. Doria, would you like to talk about the same topic a bit, and from your perspective at Care First?
Sure, definitely. This is definitely probably the second question we get in from providers. The other is claim submission. So Care First published a ICD-10 request guidelines authorization request guidelines document, given it's a little complex of a topic. So that's available on our provider portal, and we kind of give that out through our provider reps. But so our authorization request will be accepted on July 20th. That you can quote for ICD-10. We're a little bit different though from AmeriGroup though. So Care First, if it spans the October 1st date, they would actually have to be split out. So we wouldn't be able to, if there's an existing authorization request that does span that mandate date, it would have to be revised. And so we've been trying to communicate that to providers early. So we communicate that out through all of our quarterly meetings, all of our webinars with providers. It's up on the provider portal, it's up on our FAQs, it's in our e-blast. It's anything we can do to get out to the provider groups. And then right now what we're trying to work on is focusing on, do we have the right contacts that work on ICD-10 at the provider side? Because we have provider contacts, but it's obviously very hard to make sure we have the right ones. So we're getting that message out as much as we can. But it's, and then keep in mind that so ICD-9 and ICD-10 codes, unless it's inpatient, it's determined by the date of service, and if it's inpatient, it's determined by the date of discharge. Those are two clarifying points, but that's all in our 2-page authorization request guidelines document, which if you don't know where the provider portal is for ICD-10 for Care First, it's just carefirst.com/ICD-10.
And Stacy?
For Aetna, we are going to start allowing the ICD-10s to be submitted for pre-certifications for dates of service after 10/1, starting on July 1st. I know I did count the 90 days because
okay.
it was a 90-day window. So at this point, we're not requiring that to be submitted. So I think there's still this concern that providers won't be ready. So there's a little bit of a hedge factor for a period of time. I say that with the qualification, though, as you may know, Aetna acquired Coventry Healthcare about 2 years ago, and Coventry was well on the way for their own remediation, and there is still business on those systems and applications. And I think on the Coventry front, the requirement will be for ICD-10. So we're working with the team now to understand how much flexibility is there on that system, and could we shift it to allow both for a period, while we're sort of getting those phone calls or electronic pre-auths in up until October 1st, but that's still a little bit of a TBD. But right now, we're hoping, and we are communicating, much like I think Catherine said, we're communicating through provider newsletters, through our website. We have many requests from health systems from a survey perspective, so we've incorporated that into our responses, et cetera, et cetera.
So I think that from a testing standpoint, we've talked about testing, and we've heard a lot, sort of mixed in with your comments so far. Are there some other comments you'd like to make with testing? And Stacy, why don't you start that?
Sure. Aetna started our external testing using a stone and chisel in 2012. It was pretty rudimentary. It was an Excel spreadsheet, and I'm not an Excel expert, and I could do it. So it was pretty rudimentary, but we wanted to get started, and we were still waiting for our test environment to be fully up and running. And we identified test partners really based on risk assessment. So we looked at DRG-based contracts because that says we know where the bulk of the impact will lie, and looked at volume of claims, volume of dollars, and sort of made those decisions. And we wanted to try to get a good mix from a Medicare versus commercial perspective, et cetera, et cetera. But since then, we've conducted 6 cycles of tests with providers, with the final cycle finishing right now, actually. I mean, the claims have all been processed, and now we're in the process of starting to have the meetings to review the results. And what I really like about the way the testing was conducted, and I can say that because while it's my program, I didn't really do this. Ryan Parkney on my team has been the spearhead behind this. As we would go through the results with the health system that would be partnering with us, it was a really open dialogue. I think Stanley sort of alluded to this, that we've never had the kind of collaboration in this industry before, at least in my experience, that we've seen with ICD-10, where you have a payer and a provider sitting down to say, let's look at test results and have an open dialogue about why they changed. Why did it look like this under ICD-9 and look like this under ICD-10? And it was that environment, I think, that fostered some real learning and awareness for both parties. And what we learned from that is that we had about a 16 to 17% shift. And this was consistent, cycle after cycle after cycle. And then Brian just presented at the WEDI conference with 2 other national payers. Their results were almost identical. It was really interesting. So the shift was, around the 16, 17% range, where you started with one DRG under ICD-9 and you ended up with a different DRG under ICD-10. When we sat and reviewed those results with our provider partners to try to understand what was the precipitating factor behind that shift or the change, 80% of the time, the provider would say it was our coding. It was either incorrect coding, missing coding, maybe the ICD-9 coding was incorrect when they went back and looked at the record. So the good news is we consider that to be controllable, right? I mean, as the provider community gets more comfortable with the code set, we would expect many of those types of incidences to go away. The bad news is, in the real world, we won't be comparing 9s and 10s, right? We'll just be paying the claims that come through the door. So we'll try to sort of monitor that, because we saw the payments and the impact of payment going up and down. It wasn't across the board one way or the other. It definitely went both directions. And most of all of our partners were just saying, we just want to be neutral. We just want to have an expectation that we believe we can hold true to as we navigate through that. So that's really kind of where we've landed from a test results perspective. Of the remaining 30%, about half of those were variances that were driven by test environment. Just as you guys were talking about, you have to kind of rig your systems to make it all work, and as it just creates some fallout that we won't expect to see in production. And then about 15% of the 16% were what we call uncontrollable variances. So these are variances we expect to see as we move from ICD-9 to ICD-10. Maybe the code set is more specific now, so we're actually seeing a change. And again, those variances went up and they went down from a reimbursement perspective. So, we're just trying to understand, well, what does that mean to our book of business? And, how do we need to talk to our health systems about that if that's appropriate? So that's kind of our result.
That's good. And so, Doria, do you want to go ahead and also address that topic?
Sure. So, like I mentioned before, end-to-end testing starts soon, about a week. And part of that is because all of the internal testing that we had to do prior was a bit more complex than a lot of the providers that we've talked to assumed, and so we've had to have a lot of dialogue with providers to explain why we've had to delay until June. But the way we selected the provider group, we just had our kickoff a couple weeks ago. It was basically similar to Aetna. We wanted to make sure we had a wide variety of providers, as well as, just making sure we incorporated the different provider types and specialties, but there was also historical claims analysis that went into it to determine the provider group. We had a very active provider call with about 250 providers on our call a couple weeks ago, and so there were a lot of testing questions that came out. We are testing via our 4 main trading partner clearinghouses, so that's RealMed, Availity, Relay Health, and of course I'm blanking because I'm up here in front of all of you, Allscripts and Indion. So we got a lot of questions of what if I don't work through that? What if that's not my main clearinghouse? And so we've put together a very detailed list of question and answers to try and help all of our provider groups through the testing process. So the testing is going, we haven't seen the results yet, obviously, but we are doing also internal financial neutrality analysis as part of all of this. So we're hoping to be able to publish the results from the first phase of testing, which will go up through July, and then we'll have a second phase of testing, which will end at the end of August. So no results quite yet, but so far things are going smoothly.
Okay, and Kathy?
So from an AmeriGroup standpoint, we took a slightly different approach to provider testing. Rather than looking at the claims data, which we did look at, and high volume, high dollar type of things, we chose instead to say, there's a lot of providers out there that want to test and need to test, and we're open for testing with providers. If you're a PAR provider with us and you're able to submit compliant 837s. So for the moment, we're open to any and all providers that meet those criteria and want to test with us. At some point, if that becomes unsustainable, we may have to back down from that approach. We've got a lot of providers in the hopper right now, both in Maryland and across the country. We've got, some we tested starting last year. We've been in live testing. UMS was one of the first providers actually at the table testing with us, and I can agree with Jody. Nick's doing a great job. But it's interesting. There are a lot of challenges that we're seeing that we're working through with providers in just being able to have providers get those 837 files either through a clearinghouse to us or in their own hands and to us. And as Stacy said, it's really new ground for all of us. Provider payer testing is not something that the industry was set up for. I give a lot of credit to the clearinghouses before ICD-10. I don't think a clearinghouse ever participated in bridged testing from the payer or from the provider to the payer. I don't think it had ever happened before. And the clearinghouses got to the table and created ways for that to happen and supported that for ICD-10. So I give them a lot of credit in that regard. We couldn't have done this probably had that not happened, I have to say. That said, though, there are still a lot of challenges, and there's still a lot of, you've got your silos, and you have relationships with this entity, but not that entity, and one's testing one way and another way. And so I think as we all move into this really heavy testing phase, the thing we've got to do is kind of work together and try to figure out, there is a path, you just got to figure out what that path is in order to be able to support that testing, provider to payer testing.
So taking that a little,
I'm sorry,
go right ahead.
Brian would kill me if I didn't mention this. I saw people writing down as I was giving numbers. So Aetna has published all of our test results on the Aetna.com website in the provider section. There's the portal there. There are 5 webinars. I think each one is about 5 to 8 minutes, so you can sort of pick and choose. They go from, sort of what the test approach was, to inpatient results, to outpatient results. There's high level and detailed results, so you can really pick what you have interest in. So he's led all of that, but I didn't want people to feel like, oh, I missed that number, and that's, it's all out there, so.
Okay, thank you. As we were talking about sort of the testing and issues that come up, I'm going to ask a dual question. Okay, and the question is, are there any contingency plans for the provider who can't submit ICD-10? And with that, what are your main concerns with regard to preparedness on the provider side? Kathy, you want to tip that one off?
Like with the off, I have to give the hard statement, right? There isn't that I know, and I'll be interested to hear about my peers, but there isn't a contingency plan that we can really do for a provider who isn't going to submit compliant claims. compliant is the requirement. You've got to be able to submit a compliant claim, and beginning October 1st, that includes ICD-10 codes. We can't code, as I said in the last comment, we can't code for the provider. We don't have the medical records. So there isn't a contingency in that regard. We're here now. We're here to test. We're here to help in any ways that we can, share information. We're doing a lot of one-on-one meetings with providers where they're reaching out to us and providing any insights and guidance we can. We're here now to help that readiness. This is the time. And it isn't going to be October 1st. That's going to be an unfortunate story, I think, come October 1st. Yes, the second part of your question is about the concerns, and the concerns really do lie where that popular theme has been all along. It probably isn't most of the folks in this room. It certainly isn't the folks on the panel. It becomes that smaller provider, that provider who maybe, if you look at the big picture, they don't even have capacity to do testing right now. They may or may not have capacity to get to readiness, but they certainly don't have capacity to get to testing because they're just busy doing their day job, and they don't have the infrastructure and the manpower to provide resources to make that happen. And so that's where I think many of us in the industry are concerned, is that smaller providers, those providers that none of us are hearing from. And because you've got that silence, because we don't have a forum like this with those providers, I think that's where the fear factor lies. And so I'm grateful for this kind of a forum. I'm grateful to be able to do the testing that we're doing. It's going to help us all in the long run, but there's still that unknown out there, and that unknown is where my unsettled point is.
Right, and I think that from my background and working with some of those smaller providers, they're really just now deciding whether they should be considering ICD-10 now. Considering, not even doing it.
Yeah.
So Daria, do you want to also talk a little bit about that?
Sure. So in terms of a contingency plan, if a provider is unable to submit an ICD-10, so CareFirst is not still processing, so that's something that we've made very clear. So no, I mean, if the provider can't submit, similar to what Kathy said, then we're really hoping that all of the readiness activities that we are participating in at least help. But again, as Kathy said, the unknown is something we're very concerned about. It's something our CEO is very concerned about. And, we are right now, so one of my roles is to work with our trading partners at an ICD-10 level and try and get a better understanding of what services do they offer if a provider comes in, and even after testing, right? So if we see the testing results and we see how those go, once we go live, are there services that the clearinghouses offer today that can kind of identify and pinpoint where things are going wrong, where data coming in is not as we would expect, and do they offer any support back to the provider to help them through that? And so we're working with our trading partners to see if there are additional services they can offer or reporting they can start running and things like that, so we can get ahead of this, because readiness is, from a provider side, is my biggest concern right now. And we're trying to figure out what else can we do, because we can't, CareFirst can't train the providers. There are obviously a lot of resources that we push providers to, but right now we're doing everything in our power to see if we can get ahead of the data to understand how really ready are providers. If we have great data from a large provider groups, but we have less data from smaller.
Right. Stacy?
Yeah, from a contingency plan perspective, I think it's pretty much what we've heard from my peers here. We're not dual processing. We will expect the claim to be compliant, so coded with ICD-10 codes for dates of service after 10/1, and we'll reject them if they don't have those codes. And, this is a hard conversation to have with senior leadership in organizations. So I don't know how many of you are having these conversations, but, our leaders are thinking about, well, what does this mean for our reserving process, right? Because we count on understanding the flow of claims and dollars. I mean, this is how we run our business, and now we don't know. I'm having these conversations with our operations team. Well, what do you mean we could reject tens of thousands of claims every day and then know those are all coming back at some point, and it's going to sort of hit our operational units? So it's not a desirable place for anybody to be, but I think it is where we all are. So it is incumbent upon all of us to do what we can to try and encourage providers to be ready. To that end, that is our main concern. We ran a survey of contracted providers. It was a SurveyMonkey survey that went out through email. I can't even remember now, it was like, I don't know, 200 or 300,000 different email addresses where the survey went. And it was interesting because if you look at the WEDI results from their surveys, our results almost mirrored it, even though our N from a survey perspective was much, much higher. So if you're a health system or a facility, you're ready. And if you're an outpatient or professional provider, you've got a 70% level confidence or somewhere in that ballpark. So, that really is, because it may not be the dollars from a volume perspective, but it certainly is the claims from a volume perspective that we're concerned about. So we're sending postcards and continuing to reinforce in every way we can, we're ready, we want you to be ready, how can we help you, et cetera, et cetera.
Yeah. I think it's going to be a tough time. Yes, go ahead, Dory.
I forgot to mention was, and I'm sure you guys might agree with this, contingency on our side. So one thing that one of my teams does is all the training for anyone that's member and provider facing. So we also have member concerns, right? The member might, especially if there's a non-participating provider scenario, that's been another big concern for CareFirst. So we're making sure anybody that's provider or member facing is trained adequately on, trying to identify this is an ICD-10 issue, first of all, and then trying to help them navigate through how to resolve their problem.
I think you brought up a very interesting point. Depending on the part of the country, and Maryland has a high participation level, there are areas in the country that have varying participation. And so when we talk about the non-PAR doctors, I think that they will provide a significant challenge because they're in that sort of in-between land. Right. They may or may not be getting information from you. They may or may not be looking at the portals. If they're not a provider, then there's going to be some things they may not be able to get into. Has there been any effort to reach out to some of those non-PAR to provide information to them?
This is Stacey. I'll start. Not overtly. Our information on ICD-10 is public information. So to the extent they're interested to understand what our position is, our expectations are, our readiness, our test results, any of that is available. So we do have some ICD-10 related trainings that I think maybe are on our secure portal. Mm-hmm. So if you're a participating provider, you may have access to a little bit more information, but most of our information is available, but we haven't really we're just trying to get our arms around the participating. So, but it's a good point. We call it white space. Definitely parts of the country where that participation rate is much lower.
And I'm not making it a criticism, just a question, yep. Okay? Because I think that there is some of that out there.
Yep. Yeah, definitely. That's actually one of the main questions. We do focus groups with all of our service areas across all of the different strategic business units we have, and all of the CSRs ask me that question. What do I do when a non-participating provider calls or a member calls? And so we've actually factored that into our training, like I mentioned, but we aren't doing focused communication to the non-participating provider group, but similar to Aetna, all of our materials are available on the portal. Obviously, the non-participating providers don't get that high touch mm-hmm. that we have with our provider relations group. So
I don't have anything different to add in the sense that our information is available and we're not doing anything specific for non-PARs. Excuse me. What I would say, though, is I have a hope, and that hope is that they're participating somewhere, and that's getting them ready. If not for us here and for Maryland, it's getting them ready, and it'll carry over.
Mm-hmm. Okay, well, thank you. Any other comments you'd like to make with regard to the I-10 concerns, other points that you'd like to make? And Kathy, why don't you start that off, too? I always ask you the hard questions, right? You have to quick thinking.
I thought I was going to benefit from being the end of the line and sitting
down.
There's so much. It's hard to pick where to start and what to say. I might emphasize a few points, to some of what was discussed on the hospital side. What are we really focused on now? We're obviously really focused on testing. We're here. We're not shutting down testing. We don't have a defined window. We're open and working individually with providers one-on-one with regard to testing and still have that welcome mat out. So if this is the first time you're hearing this, reach out through your provider relations reps, and they know how to get you brought into our testing processes. otherwise, besides testing, which really is the paramount focus right now, that internal readiness where we've got go live starting and things starting to happen and move forward. So that's obviously a focus. But the next tier of focus I think that's worth mentioning is it's that how do we deal with these things kind of a focus. And so we're testing on our side and readying reporting and analysis type things, tools that are going to let us try to spot problems. And so reject reports and denial reports and things that are focused on ICD-10 that will let us proactively identify those providers that are struggling and reach out to them and encourage them as the go live starts to happen and the problems start to mount. So it's that kind of thinking and thing that we're engaging now to see how are we going to sort of do damage control if in fact that starts to happen. Optimally, I'd love to think that we're all going to get there and everybody's going to be ready and business is going to move on. I think it's not. And so then it's how are we going to address and how are we going to kick into that next level of identification and helpfulness that is going to be necessary to keep us all moving. We want to pay the claims. We want to get them in. Yeah, I think we all are in that basket. You heard Stacy and Doria say there's impacts to all of us if in our operations, our finances, et cetera, if we don't get the claims in and pay them on those first go rounds. It's not that we don't want to do it, but they've got to come ready.
So I think the only thing I'd add to that from a Care First perspective is, so even though we don't train providers, we are doing a lot of work for our provider relations group. So I know a lot of you probably are aware of if you work with Care First or Care First provider rep, but any provider-facing quarterly meeting, I have my ICD-10 team there. Any webinar, so moving forward and starting in June, we're going to have an ICD-10 section, and we're really reaching out and making sure ICD-10 representation is there from the provider side. In terms of testing, we are looking forward to seeing how the testing goes and what the results are going to be. We are, a lot of the feedback we've gotten from our clearinghouses is, can you please make the results and your lessons learned published up on your portal? So that's something that we're definitely looking into. Also, anytime there's a situation where we get a question from a provider that we have not yet answered through a FAQ or through a training or something that's available, we update those. So, we have existing documentation. I know sometimes it's just clicking through that is not the easiest thing to do, but we have claim submission guidelines. We basically took CMS's claim submission guidelines and made them specific to Care First and a little bit easier to follow. Those are up on the Care First portal for providers. We also have the authorization request guidelines that I mentioned. So we also have an inbox that my team monitors around the clock. Well, they go to bed, but we try to get back within 48 hours. And so we're really doing everything we can to sort of address the concerns. The other thing that we're doing up front, and we've gotten a lot of feedback from our large groups and small groups, the consumer direct strategic business units is get ahead of this on the IVRs when providers call in, put a message up there. Train the CSRs a few months early on any questions they could answer when the providers call in and might have questions about ICD-10. So that's something we're focused on right now.
Okay. And Stacy, would you like to add something?
Yeah, I think I would just highlight, it's actually interesting, we call our team exactly what University of Maryland does, the Rapid Response Team, and it was created in a state of emergency after 5010. So we found that we had fallout not because we hadn't tested, but it's exactly what you said, we didn't have the bridge, right? So it was the provider, the clearinghouse, and Aetna, and it fell out somewhere in between there for us. So we had to pull together this team, and it turned out to be a great business practice. So now it's sort of how we approach this. But what I would recommend to everyone is that while you're thinking about readiness, while you're thinking about testing, that you're thinking about how am I going to know if something goes wrong? How quickly can I know it? And how am I going to know that it's because of ICD-10? I like to joke that if the lights go out, some senior leaders calling me saying it's because of ICD-10, right? So, that's coming. So just be armed, if nothing else, defensively, with your ability to say, yes, I understand that you have an issue in this business line, but let me explain using these metrics why I don't think it's ICD-10. Or you have an issue, these metrics tell me it's probably ICD-10, and here's our planned response to that particular concern. So at this moment, it's a really good strategy, I think, to be focusing on, what are the metrics that are going to tell me if I have a problem? Do I have any that are going to tell me pretty quickly? And then what is my plan to account or to address that if it does happen?
Yeah, I think that's very helpful. And obviously, by the presentation today, we've got 3 large insurance companies that have been very much involved in running this through and working with the providers. The elephant in the room is all the others, both the hospitals as well as the other insurance companies. That's 2 big elephants. But I think that that's going to be a challenge for all of us, because there are people who are in varying levels of readiness or awareness of reality. We still have some that are hoping that it's going to somehow, legislation is going to go there and it's going to change. And I keep saying, no, don't hold your breath on that. So we're ready to open it up for questions. Yes, very much.
I do have one question for Stanley, our moderator. Do you know if there are any non-covered entities that will be ICD-10 ready by October 1st?
Sure. And it's important to recognize that the HIPAA requirements and the requirement to move to ICD-10 applies to health plans and health care providers. Workers' comp has specifically been exempted from HIPAA for a long time. In fact, since the beginning, no workers' comp plan, and that's state by state, is required under HIPAA to follow the HIPAA transaction standards. Certain states have enacted legislation to require the workers' comp plans in their states to follow HIPAA standards. Best that I know, at least in Maryland, my information is that the Maryland workers' comp will be using ICD-10 for submission. So from a provider perspective, you don't have to keep remembering the ICD-9 code and submit that to workers' comp. You can submit the ICD-10 code. Now, for those of you that deal with workers' comp in other states, let's see, there was a survey done, for example, let's see, what's the information on Pennsylvania? Pennsylvania, they didn't know at the point, but you'd have to check state by state for the State Insurance Commission to see whether or not those state workers' comp plans are requiring the move to ICD-10 or are actually not accepting ICD-10 and using ICD-9 codes. So that's a little bit of a glitch that certain providers might be facing, and that differs state by state.
Thank you. Now it's time for our question and answer session. So if anybody has any questions for our panelists here, or I guess not our moderators, but our panelists, please. You'll answer questions too. Okay, great. Please raise your hand, and if you're in the audience or if you're on the webinar, just raise your hand there too, and someone will relay your question.
I'm coming from health system, and so 6 hospitals where we've been doing some testing with payers. And for HIN perspective, there's always been challenges doing dual coding as well as test environment challenges. So we started a conversation recently internally to say, hey, can we do some volume testing? And then looking deeper into it, we realized the pair that we have coming up, we just don't have enough volume to do that pair testing. So I'm kind of asking the panel, those of you that have done full dual coding or done volume testing, what have been the feedback?
Can you maybe elaborate on what you mean by volume testing? Is it just sheer numbers of claims, and what was the basis for what the right number is?
Well, you know, from the testing that we've done for most of our payers is within maybe like 20 to 50 cases. So talking about when you open the floodgates to maybe like 100 or 1,000.
Well, I can just say for Aetna, we've had partners in our collaboration that have submitted hundreds of claims to us. So I don't know if that's considered volume, but it, you know, was more than 20, I suppose. Interestingly enough, with whatever the volume, the results have been very similar. So if that makes you feel a little bit better, that, you know, what we tried to do as we selected claims to be tested, we tried to be representative of the case mix that the provider would be submitting, so that whether it was 100 or 800, hopefully we were going to get proportionately kind of what they would normally be submitting. That was a strategy to account for some of the limitations on volume, but that was our approach.
Yeah, I think one of the concerns that a number of providers or clearinghouses will have is come October 1st when the regular claims flow starts happening with ICD-10, is there going to be a slowdown? Will you be able to process ICD-10 in the same manner and as quickly as you have in ICD-9? I think that's something that we certainly don't know, and unfortunately probably won't know until October, because there's all the thoughts about, will you be able to auto adjudicate as many claims under ICD-10? Many plans are trying, I don't want to say desperately, but trying very hard to make sure that the auto adjudication rate and other factors stay as close as possible to the ICD-9 experience. But again, until all the providers start submitting claims, we won't know. A couple of health plans, I know the Humana folks did some sort of internal volume testing, and they're relatively comfortable that they'll be able to handle that workload. But it's, again, this is sort of a two-way street, unfortunately. It's tough for the health plans to know exactly what's going to be coming in on October 1st. Difficult for you as providers to know exactly what's going to be coming in.
The only thing I would say on behalf of Care First is we have tried to do some internal analysis of that, so looking at the same submission volumes that we have today, using the tools that we have to determine, what would that look potentially in the ICD-10 world, and just making sure that we can get ahead of that. And then the other thing that we've done, which is a little different than your question, but helps address it on the payer side for us, is we did a change impact assessment across every business process area in the claims space, and kind of tried to look at, okay, well, where do things currently drop to a manual queue for different reasons, and do we need to staff up in those spaces? And so we've done a lot of analysis on business processes as well as staff readiness in terms of where do we temporarily need to staff up in anticipation for some of these things like call volume. And we are really working hard to try and make sure people stick with electronic submissions, and we're working pretty hard on that to help in that space.
Yeah, I think the good news is that because it's, service dates October 1st, at least on October 1st, you're not going to be slammed with a million claims, that have ICD-10 codes. October 2nd or 3rd or 4th maybe, yes, but it'll sort of be gradual.
So I believe the payer survey results said that most, if not all, payers were going to adopt the CMS rule for split billing required effective 10/1. So admissions prior to 10/1, we bill through, the 112 type of bill, and then 114 for after 10/1. Will there be a clearer direction as to how hospitals and providers are supposed to handle claim submissions where the patient is actually an outpatient during the turnover time, 9:30 to 10/1, maybe an observation, or where bundling is involved, where we have to consolidate within the 72-hour rule, an outpatient service that occurs 1 or 2 or 3 days prior to an admission that occurs after 10/1. I realize it's a very specific question, so we might not be there yet, but this is something that bothers me.
Yeah, so I would say that it's a little bit deeper question than I can answer at this stage in the game. High level, CMS's Transmittal 950 is what we're following, and it basically covers those scenarios. You're right, the requirements of processing and staying compliant with that will require splitting. They will require things that you will split along the lines of dates of service or date of discharge. So if you're on that inpatient stay, your date of discharge would drive, you could run off of that ICD-10 code. However, you do have professional services that are tied in to those same claims, and the need to split then becomes driven by that based on that date of discharge or date of service and when those claims are going to get submitted.
Yeah, I would say, every payer has to know those answers because you have to set up your system. So, someone asked themselves that question and answered it at some point. So the question is, communication of that. And I think I wrote down the off guidelines that you mentioned because I'm not close enough to that level of detail. But, I think it's a good call to action for us to make sure that to the extent that level of detail has been discussed and decisions have been made and directions set, we need to make sure we're making that available to the provider community. So it's a good question.
Yeah, and I think the consistency from plan to plan is also very, very important. And to the extent possible, if everyone is doing it approximately the same way, it makes it a heck of a lot easier for hospitals than trying to. That's
probably not likely to happen, though.
I'm just saying.
Do we have anyone on the line? Oh, sorry. Well, let's see if anyone has any questions out here. Greg, any questions?
Not yet.
Okay.
I got to chat with Linda.
Okay. Someone in the audience had their hand raised.
Yes, my question's for Dorian. When we were on the call with you regarding, or maybe not you, but on the call last week regarding the ICD-10 testing, end-to-end testing, the question was brought up about Relay Health shutting down operations on 7/31, but your testing period extends through August. And I knew you guys were going to reach out to them, and I didn't know if anything came of that, as well as they only release their claims in the testing environment to the payers once a week. So those were the two concerns that I had.
So that's very timely. So we have monthly meetings with Relay Health, and we have daily testing calls with them. And so their main testing point of contact, she confirmed with me that they cannot extend their testing timeline into August. And so I let her know. I just wanted to make sure she was positive, because if that was the case, all of the providers that we had that go through them, we would have to communicate to them that they would have to stop their testing with CareFirst, I believe, on July 28th. So we are going to give a formal response to all of those providers. I just wanted to make sure that her leadership was okay with me communicating that message. But that's so far my understanding is that they would have to stop at the end of July, which means any provider we try to test with through them would have to stop at the end of July. And then your second question, we're still working through that. So one thing I didn't really go into a lot of detail that we wanted to make sure we did prior to starting end-to-end testing was connectivity testing, because a lot of the lessons learned that we had with clearinghouses prior to this was there was connection issues in their test environments between our test environment and theirs. So we just are wrapping that up now and trying to work with them through the connection that we established. How often can they submit the claims? And because they've asked us, based on our claim submission requirements for testing, how are they going to batch those and send them to us? And so we're working through that with them and kind of have given them a limit of how much they could give at the end of the week based on the volume we can accept, but it shouldn't impact the provider.
And are there any opportunities to increase the number of claims that we can release per day, since we can't extend past 7/28? Because I think that's only maybe 8 days.
Yeah, that's a great question, and one I'll take back to my testing leads, only because I think what will happen in this first phase of testing is we'll see how many providers actually submit claims, right? So if less due than we originally anticipated and opened it up for, then we can probably sort of shift and figure out, okay, well, now we can let certain providers submit more. Or, it's going to be kind of, we'll have to figure it out as we go. A lot of that, unfortunately, is based on our internal bandwidth and the test environment being shared amongst multiple groups at CareFirst. So right now, we still have to stick to the one claim a day scenario, and then after, I think, a couple of weeks, we'll be able to figure out if we can increase it.
Okay. Thank you.
Yeah.
Yeah, just a couple comments. That connectivity issue and the ability or inability to connect, it came up in the Medicare end-to-end testing. Although they reported close to a 20% error rate, the vast majority of those errors were because of connectivity issues that had little to do with ICD-10. The ICD-10 issues were a very small percentage, so it's very important to get that right. The other thing I want to emphasize is even if you're not able to do external testing, the ability to do internal testing and do the dual coding ICD-9 and ICD-10 is actually very critical, especially for hospitals, and run it through the DRG package if you can. You don't have to wait for the payer. If you're being paid on contract, well, you know a whole bunch of stuff. If you can actually compute the DRGs internally, you can see if there are any shifts coming around.
Okay. My question is authorization-based, and it's similar to Bill's. It's very specific. For recurring accounts that are going to span the dates of service, and just comparing the two. So a chemo patient that will start treatment on 8/1 and finish 11/30. As we call to obtain those authorizations, or we already have them, we need to use a 9 code up until 9/30 when we're dealing with Care First. And then utilize the 10 code 10/1 forward. And then with the AmeriGroup, we can use the 9 code, and it will carry all the way through until that patient's treatment is complete.
Yes, for AmeriGroup, to what you said, and the reason is because we're gonna try to match on diag, but we've got second and third level matching that we can take and invoke. So the existing auths, the spanning auths, will be able to be supported and support the claims that come in.
And then in the Care First area, if we submit, if the 9 authorization lands on that 10/1 forward account, it would deny.
Correct. It would have to be submitted in 2 different requests.
Okay.
So we're trying to get ahead of that. We know that is a big groan for, it's a lot of manual effort. So we're trying to get ahead of that right now for anything that's existing to get providers to go ahead and get prepared to put those in once we can accept them on July 20th.
We don't have a field to capture a second authorization number for the same claim.
Right.
We don't have that. None of our systems do. That will be.
Yeah, I just made a note of that. No. Yeah, but you have to record. Yeah, you have to, as an access representative, or in many cases, these are outpatient departments, will have to capture both codes, report both codes, and then know 1 minute, now it's 10/1, use this code. So it's going to create some challenges.
Yeah, I think what we're going to have to do is we're going to have to get the authorization for the ICANN, record it somewhere in the patient record, and then it's going to be a manual effort to go back through everything and change it again. And that's something we need to be prepared for.
Right.
And to know how many insurance companies are going to be requiring that change as of October 1st. I think our recurring patients, our long-term patients, where we had that situation, are going to be a challenge for us.
Any other questions? There are no questions online. So we can wrap things up. We're a little early, about 2 minutes. That's because we're women in charge up front. We're on time.
Well, other than Stanley. Okay, I mean, I don't know definitely, but I think it doesn't make
very interesting discussion of gender transformation and ICD encoding back a ways, but I don't plan to undertake that yet. I actually did notice that I was the only male. Up here, I felt a little bit inferior.
I would like to thank all of our panelists and our moderators. Can you give them a big applause?
Yes.
I think everyone did a great job. I hope you found the session informative. If you have any further questions, just hold them to yourself because I don't know what to do with them. No, I'm just joking. Just you can send some to me, and perhaps I can try to forward them on to the appropriate person. Okay? Well, thank you for attending, and thank you, participants.
Thank you.
And it has to be provider education. So.
We're allowed to